with this, we will move forward with the next presentation coming from Sasko Kadev, who is a great friend. And I also know that he's fond of the mountains and also a great fan of Dalai Lama. And every time he visits India, he makes a point to go to Nepal and touch the peaks. So over here we are with Sasko, who's an ardent radial interventionist. Over to you.
Thank you very much. Atul, it's my great pleasure having this opportunity to be part of this great session. So I will share with you some of my personal experience with a challenging radial access. So why we consider radial access for carotid stenting? It's very important to appreciate that there are some femoral access is associated with some kind of unfavorable events, and access site complications are the most common adverse event after carotid stenting from the femoral approach. And most technical failures are related to a complex aortic arch. And femoral environment is not so predictable in terms of risk of bleeding and vascular complications. Furthermore, carotid stenting is difficult and almost impossible in patients with a significant aortoiliac disease or occlusion, in patients with tortuous supra-aortic arteries, particularly sometimes in a bovine aortic arch. And what is also very important, let me remind you about this pathoanatomical finding that the most significant atherosclerosis disease is located at the descendant aorta, followed by the aortic arch. So whenever we are doing procedures on the femoral approach, we are pretty aggressive to this very vulnerable part of the aortic wall. And contrary on when we are approaching from the radial access, we are avoiding this very vulnerable part of the aorta. So whenever we are considering radial for carotid stenting, we have to know the size of our access artery. We have to be aware of the aortic arch and a common carotid artery takeoff, and of course, type of the carotid lesion. So I will share with you several different case scenarios in patients that presented with acute carotid syndrome. So here we can see what the importance of pre-procedural angiography. We puff just a few ml of contrast with, and we know the roadmap and the size of the artery. In this case, we used Asahi 7.5 coronary guiding catheter, and it was a case with suboccluded left internal carotid artery bifurcation. In this case, we use a road saver double mesh stent with this final favorable outcome. Next patient is again very symptomatic patient that presented with amaurosis, and it was case when we approached from the right radial access. Now you can see the importance of pre-procedural angiography. You can appreciate this tortuosity and this spasm in this artery. If we are not aware of this, we cannot use this access in this particular case. So we did injected some additional vasodilators, and artery improves much. And that's how we prevented complications. So with the Simmons 2 catheter, we can appreciate this very complex ulcerated lesion at the level of left internal carotid artery. In this case, we are demonstrating this wireless approach. So over the very stiff braided Simmons 2 diagnostic catheter, we are advancing a very flexible shuttle sheet of 5 French. And we have this access particular below this target artery, and this is the final result with adapt stent. So this is a lesion pre-procedure and after procedure. Next case is very particular patient, high bleed increase patient on oral anticoagulation that presented with concomitant acute carotid disease and acute coronary syndrome. So in this case, we use ulnar access because radial was occluded. So there was no radial, but there were very good collaterals from interosseous arteries. So it was safe to proceed with ulnar access with a 5 French shuttle sheet. And here is this very complex ulcerated lesion of right internal carotid artery. So in this case, again, we use double layer mesh stent with a good outcome. Next case is a patient with a target right internal carotid artery presented with a minor stroke. So in this case, we have a suboccluded and very slow flow to the right internal carotid artery. and final outcome with, again, with a mesh stent with a good distal runoff. What about patients with contralateral occlusion and patients with a high risk for carotid stenting? So this was a case when we use a distal radial access. So distal radial access is in favor of lowering bleeding from the wrist side and also lowering the rate of radial occlusion. So here is a pre-procedural angiography, and in this case we have a occluded left internal carotid artery with diagnostic with Simmons 2 catheter, and here is our target of right internal carotid artery. So we have a 5 French shuttle sheet through distal radial access, and this was deployment of a mesh stent, and in this case we use a post-integrated post-dilation balloon with a filter. It's a Paladin system, and this is the final result in this particular patient. And also a very good distal presentation of anterior circulation. What about large bore devices? One of the most important disadvantage of radial access is that we cannot use this for a large bore devices. We know that MoMA is at least 8 French device, and that's why we developed this technique of sheetless MoMA insertion. It means you need 8 French introducer, and it is 8 French compatible. But when you put it as a with sheetless system, then it is much lower size in comparison to a radial artery. So we have an endovascular clamping, advancement of a stent, and this is the final result in this particular patient. And this is the last case I want to share with you. It's one of the newest development in a carotid field. It's an integrated 1 catheter NeuroGuard, which consists of a filter, stent, and post-dilation balloon, all in one, 3 in 1. So here is the presentation of a demonstration of this filter, stent, and post-dilation balloon. Very ergonomic, very easy to use, and very easy to deploy. So again, the importance of pre-procedural angiography. NeuroGuard is 6 French compatible. It means 6 French inner diameter. So it means 8 French introducer. So in this case, we have a very tiny radial artery and high takeoff of radial artery. But when you know this anatomy, you can accommodate your strategy. And in this case, we use 8 French Asahi system, and target was left internal carotid artery. So here we have a deployment, actually positioning of a device. Here is the stent, and we deploy a device based on the stent location. So here we have a deployment of filter, stent is deployed, and we have post-dilation in the same act. So we are decreasing all the possibility, all the steps. So in one device, we have 3 procedures. So at the end, I would like to conclude that one of the most frequent mistake when you consider wrist access is to perform radial only when femoral is not possible, or to consider radial in some particular patient subset. At least in a learning curve, you have to invest in your practice. So you have to start with diagnostic and slowly move to procedures. And of course, one of the mistakes is to have high threshold for a primary radial access selection. So my key point aways are that radial access is a feasible and safe procedure, but you need some previous radial experience. First, you have to invest in your diagnostic from a radial, and then you can move to carotid stenting. It allows easy access for carotid stenting in difficult anatomies, particularly bovine is very user-friendly access from a radial side. And of course, most of the right carotid arteries. It allows early patient mobilization, and of course, very important, a lower rate of hypotension. So we have a lower rate of hypotension, which is very important, and we allow early patient mobilization. What is also very important, we almost are able to eliminate bleeding complications, because always you can compress your wrist arteries and decrease the risk of bleeding complication. We can potentially reduce the risk of aortic embolization, because sometimes we are creating from a femoral access contralateral of our target artery embolizations. But at the end, we have to accept that we need further studies and more broader experience before recommending wrist access for carotid stenting as a primary approach over well-established femoral access. Thank you.
Excellent presentation. And this is entirely new way of doing carotid stentings. Most of the orthodox people have always gone for the femoral approach. So, but there are so many advantages which are inherent in this technique, but one has to get familiar. May I invite Dr. Mirwat Alasnang from Jeddah, Saudi Arabia. So Mirwat, can you unmute yourself and make a comment as to how would you prefer a radial approach over a femoral approach when you're doing a carotid stenting procedure?
Yeah, hi everybody. Thank you for the invitation. We, as the speaker mentioned, we were actually very hesitant initially in our experience to move to radial. We were concerned about spasm that we often treat with, vasodilators and more sedation, which conventionally we were avoiding in carotid stenting. So in carotid stenting, we actually try not to sedate the patient, give them toys in their hands, and ask them to squeeze. And throughout the procedure, as we dilate, as we deploy the stent, we feed the filter. We always ask them to count and so on and move their, and we want them to be awake for it. And the main concern from transferring to a radial approach was that we're going to lose that if the patient spasms or requires dilators. But I think it's a process. So you have to select your low risk cases first, be very generous with, trying to get access the first time. So get an expert radialist to get your radial access. So instead of puncturing several times and inducing spasm, perhaps ultrasound guidance helps in this area. And we even trialed the railway system at some point in time with our carotids. And we don't use it at the moment, but I don't see a contraindication if you transition into it.
Excellent. So is there a right radial or a left radial choice when you do the left carotid or the right carotid? What do you say, Sasko? And
I'm primarily left radial. Go ahead.
Yeah, one of you. So Sasko, you want to take this, and then we'll again take comment from Mirwat.
Yes. So at least in our experience, right radial is preferred access. So if we cannot do procedure from a right radial, from either a radial is not available, it's even occluded, or it is very tiny, small vessel with a loop, then we move to the ipsilateral ulnar. So we have a pretty broad experience with the ulnar access and no single hand ischemia. It means not just radial and ulnar arteries are vascularizing our hand. We have a extensive collateralization and we have interosseal arteries, anterior and posterior. So hand ischemia is not a significant risk. No single case with a hand ischemia. And of course, sometimes when both radial and ulnar are not available, we use a left radial. But left radial is not so ergonomically and anatomically equivalent to a right side. So either for a right carotid and left carotid, a right wrist is preferred access.
Dr. YVC Reddy, any comments from you on the radial aspect?
Yeah, being aggressive radialist in coronary intervention work, at least I think we should. I'm really impressed by Sasko's work. Excellent. And in fact, the point of distal radial catheterization probably would save a lot of artery ahead for further coronary procedures as well. I think that's a way to start. Even coronaries wise, we are now shifting to distal radial as a first option, and then the second and third procedures as further vascular works are needed. We still have a lot of work can be done. And for renal stenting, of course, we are always doing a left radial procedures. It makes it very well. And I suspect, I have no experience with radial carotid stenting, but I suspect left radial should be an ideal one for at least certain types of right-sided carotid arteries.
Excellent. Max, do you want to make a comment? Do you prefer to use radial access?
We were not very much pro radial access because we are femoralist in the beginning. But really, the work of Sasko Kadev in the last years impressed me. I think it's an excellent technique. Probably, of course, it reduces the hemorrhagic complication and local complication. But I would say the problem we have today is that there is no excellent device for this procedure. I think the problem we have is that the companies has to develop devices devoted to this approach because we use other devices, but they are not really well adapted. The selective diagnostic criteria are not absolutely well adapted. You have to change before going there. you don't have, we are obliged to use several guide wires before accessing to the external carotid, etc., etc. So it is probably for, in our center, a more demanding technique. Although I think it's the way to go. But in my case, I was for the last 25 years promoter of carotid stenting. And for me, it was extremely important to convince the surgeon to do it. And if you ask the surgeon today to do a radial approach for carotid stenting, it is something almost impossible. I know only very few people that are able to do it. So I think this is why we try to teach the vascular surgeon to do femoral. But I am very much, as a cardiologist, because we do 95% of our coronary cases through radial for this technique. But SASCO has to work with device company to really bring us the right devices for this technique. I think SASCO is probably the man to develop this kind of devices.
So, SASCO definitely is the pioneer of radial carotid interventions, and I'm sure he is going to work together with the companies to make it easier for others. Otherwise, it looks a little intimidating for people who have always been doing femoral approach. So,
Mathur, may I ask a question?
Yes, Dr.
What
Priya.
about the brachial approach? If you don't have radial and ulnar, you are talking about going to palmar, the diameter of the vessel obviously an issue. Why not brachial? I'm an interventional radiologist. I somehow, I mean, why you all shy away from brachials? See,
Yes,
if you ultrasound guided puncture for the brachial.
Right.
Yes, because the radial artery sometimes occludes, but that is asymptomatic in most of the cases. But when you have a brachial artery occlusion, that is always ischemia of the hand. Therefore, they prefer the more peripheral
operator familiarity also. You are very familiar with radial. I am very familiar. So, and when I see occlusions cases, which you showed when we have iliofemoral occlusion, we prefer to do brachial, and we haven't had touchwood any till now any occlusions in the brachials.
I think we have to be honest. I mean, brachial approach is probably locally more difficult than radial. It is obvious. We reserve this technique when radial is impossible, particularly, for example, in occluded lower abdominal aorta, where the only way to approach the lesion is the brachial and the radial is occluded. But I think it could not be a first intent, although we have also an excellent experience of brachial approach in cases of, let's say, iliac occlusion or long iliac occlusion or aortoiliac recanalization. But I think it cannot promoted, in my opinion, as a first intent access. I think we have to try to do radial as a first intent, but SASCO has to work on the right device to do it because we don't have a right device. Really, this is the reason.
Thank you, Max.
Excellent. So we'll move to the next presentation.
I think this has been a very interesting session. Now let me invite the director of our cath lab as well as the convener of this Carotid India, Dr. Atul Mathur. He has been the pioneer of carotid interventions in India, and he has taught us all the tricks and tips of the carotid intervention, howsoever difficult it is. So he shall be taking us through a journey of challenging carotid access. So Dr. Mathur, please.
Thank you very much, Nishit. Thanks for inviting me to this lecture now. And so we are in the right context, and this was one of the most challenging cases which I have seen in recent times. And this was the story of an 84-year-old lady, very fragile. She was diabetic, hypertensive, had coronary artery disease with a poor left ventricle function of 25%, and a history of recurrent TIAs and falls in the last few weeks. She would suddenly fall while walking to the toilet. So the family was very perturbed. There was a history, significant history of trauma fracture to the right elbow in the last 1 year, and which led to a deformity, permanent deformity of the right elbow. And she was evaluated to be having bilateral carotid stenosis, poor LV function, and she was seen by several interventionists and several vascular surgeons, and they all refused due to the very challenging anatomy this patient had. So this is a picture of this lady. We took her for an angiogram. So you will see that this lady has a bovine arch. This is a bovine arch, which will be seen in the last run. And then both the lesions, right internal and the left internal carotid, are subtotal occlusions. So this is a pulsatile, slow pulsatile flow in this 25% ejection fraction. And the right common carotid artery first loops down and then turns up, if you see carefully, to go to its course. And the left internal carotid artery is coming off from the innominate artery. Again, both of them have a TIMI2 kind of a flow. So no wonders she was having recurrent falls. So this is a challenge which I probably got carried away because everybody else had refused to do this case and decided to take upon myself. So this was the bovine arch, even more tough than the type 3 Myla's classification. So when you are faced with such an anatomy, there are certain technical issues which should always cross your mind. First of all is, can this case be done? Well, it would be very sensible if you're not confident, you avoid doing such cases rather than having such a modality on your table. Appropriate working views where you will be able to best delineate the origin of the common carotid vessels, open up the arch properly, and how to perform your procedures. What would be your diagnostic catheters of choice? Whether you would like to go with a sheath or with the use of guiding catheter. And what finally, most importantly, will be your access strategy. So there are several diagnostic catheters which can be used in such challenging anatomies. And people would probably prefer a direct guide catheter approach, 7 French or 8 French guide catheter, depending on the hardware he's going to use to access these adverse common carotid arteries. So what are the proposed access strategies for a complex arch? One should always consider the alternate accesses. Femoral is going to be a very challenging approach in these. So you can look at the radial approach from the right radial. Unfortunately, this lady had a deformed right hand, right elbow that was not available to us, or a brachial approach or a direct carotid puncture with the surgeon's help. Second thing which you can do is, once you have a guiding catheter and you need anchor support, you can put a buddy wire and take support from these anchor wires. Third thing you can remember is that there are certain specially shaped guides which will give you anchor points on the floor of the arch. So arch of aorta, so that you get better support if when you are maneuvering your hardware. And thirdly, finally, that there are certain special guiding catheters which are using a bridge wire to give support so that the guiding catheter holds in place. So this is what we had in our case. We could not go from the right radial or the brachial axis because there was a limitation. We did consider an axillary cut down or a carotid cut down, but we thought we'll first test our femoral skills. But this is a diagnostic catheter, and the slipped wire was not able to negotiate much because there was not enough support. So you can understand the difficulty of this case. So we chose to use a special guiding catheter where there was a bridge wire used lying in the arch. So this is a piton catheter where you have a side hole through which a support wire, O35 support wire, can be parked in the ascending aorta. The second wire, once it is withdrawn from the lumen of the piton catheter, will lead the catheter shape to coil itself and face into the common carotid artery of interest. So once your piton catheter is placed into the common carotid artery, you can advance your wire 1 and the wire 2 and slide your guiding catheter slightly higher as much as you're getting adequate support from the catheter to advance your hardware. So this is what we decided to do. We took a piton's catheter. If you look at the left picture, that there is this bridge wire which is parked in the ascending aorta, and the piton catheter is facing the origin of the common carotid, the left common carotid artery. That is what we decided to treat. The right common carotid artery anatomy was very intimidating, going down and up, so we decided we'll look at it later on. So this is a picture which we took of on the right catheter, and then slowly passed a 014 coronary guide wire up into the common carotid artery. So following this, we still allowed the bridging wire to stay in the ascending aorta, and then we did a balloon dilatation, pre-dilatation, without passing any filters, because we were not sure whether we will get adequate support with the filter wire. So we did a balloon dilatation and improvement of flow was noticed. Now the challenge was that we had to withdraw the bridge wire which was hanging inside the arch of the aorta. So once we withdraw that bridge wire, we lose a lot of support in the piton catheter. And would it be sufficient to hold the passage of the coronary, the carotid stent going up into the tortuous carotid artery? So we thought of using a buddy wire over here. So we took another coronary wire, a buddy wire, on the side of the previous wire which was placed in the internal carotid artery. And there you see on one of these wires, the original wire, we were gradually, nudgingly able to pass forward the carotid stent. Now, as soon as the carotid stent was across the lesion, there was no flow in the carotid artery, and the patient did not tolerate this. The patient became unstable and started moving a lot, and the pressure started falling. So we had to act quickly. We had to, based on the bony landmarks, unfortunately, which we realized had shifted, we placed the, we expanded the carotid stent in the internal carotid artery. And once we deployed the stent, we found that some proximal portion of the lesion is still uncovered with the stent. So this was our horror at that time. But then, of course, you had to go in with a second stent. Before doing that, we did a good pre-dilatation of the proximal part of the first stent so that the nose cone of the second stent does not catch on this. And then also we had to keep in mind that we have got a buddy wire which is outside the previous carotid stent. So we had to keep in mind that that buddy wire does not get trapped. The second stent was advanced and deployed, and subsequently a final balloon dilatation was performed. And finally, we got a brisk flow going up into the carotids. There was no evidence of any intracranial embolization. And the patient had stabilized once the flow resumed into the, so all this was done very quickly because the patient was not giving much time initially. So here was a case of a very challenging access where we used a very innovative new guiding catheter, which is available in different parts of the world. And with the help of this guiding catheter, we were able to successfully perform the procedure. If I was confident about the support from the guiding catheter, I may have also thought about using a distal protection device, but this is how we went. So we are open for discussion now. Thank you very much. So we'll take an opinion from Max, and Max would like to make a comment. Dr. Gary, after that.
I have a few comments.
And then Sasko.
You have chosen difficult access cases, and I think you have to have all the devices that you have present to perform such case. I think, of course, the guiding is important. There is one guiding that we are using, which is the Pardis guiding catheter, which is a SAD left and right. I don't know if you are familiar with this guiding catheter, but they are more easy to use and they help us in very difficult cases. Otherwise, I think what you have shown are the right technique to perform such difficult cases.
Sasko Kadev, your comments?
Congratulations, it was a great case, great selection of Python. I think it's Medtronic device, right?
Piton, yes, Piton catheter, right.
Yes, but this was a very, very particular case for a right radial access. Unfortunately, it was not available, but if you were able to negotiate from a right radial, your diagnostic wire will go directly in the left. You'll have harder time to go distally, but you can advance easily to, and bovine arch is great indication, but you are unfortunate that radial was not available. anyway, it was a very, very good case.
Gary, comments from you?
Yeah, bravo to nice work. I would only say that you depicted the clinical situation where the patient had no alternatives, but I do not like doing carotid intervention on 85-year-olds. But in this case, she had no alternative. So, bravo, good work.
Thank you, Dr. Klaus.
Satvik.
Yeah, Satvik, please.
Yeah, just wondering if you had considered an axillary cut down if a brachial and a radial were not available, because you know, it's quite obvious that the wire would have walked into the left carotid had you accessed from the right side. And also it would have given you the opportunity of putting in a filter, because I mean, doing this without a filter would have been obviously a difficult consideration, but great job. Many congratulations on the outcome.
Yeah, we did consider the axillary cut down I mentioned. So we thought, let's probe with the femoral route in case it works out, because I was confident about the piton catheter in my hand. But the axillary would have been a good choice in this case, correctly said. And so we have any more comments?
Can I make a comment?
Yeah. Dr. Badi, yeah, welcome.
Yeah. I think, as very rightly pointed out, if it was possible to the right radial, it would have been excellent. My only concern is when you put in a piton and in a bovine arch, and you push it right up to the left carotid artery, then probably it puts a lot of stress on the left carotid artery and straightens it. That was probably the reason why this patient had hypotension. I would just suggest that instead of pushing the piton in such a situation high up, if we use a guide liner in the piton catheter and go into the left carotid, the procedure would have been much easier. The second time when the second stent was put in, I think if the piton is staying lower down into the bovine arch initial part, and you do not have it into the left carotid, the stent would not go. So your wire, which was outside the stent, helped you in negotiating the stent, second stent. So I think a guide liner here would have been very useful to both to put in a distal protection device and to stent it also.
So we did not advance the piton up into the common carotid artery. It was always at the mouth of the common carotid. There was no way we could have sent it up, so much of tortuosity. The instability came when the stent occluded the flow in the internal carotid artery. But use of a guide liner is a good suggestion, and that can be also kept in mind in such challenging, tortuous common carotid arteries. That's a very good point you made. So any one more last comment, and in the meantime, can I request Dr. Gary Rubin to share his screen while we take the last comments over here. So Dr. Klaus Matthias and Balabaneni. Yeah.
I'm also here, yes, and I want only to mention that direct carotid puncture is also an option that was used quite a lot when the surgeons started doing carotid stenting. And I remember especially Patrice Bergeron from Marseille, who did nearly all his cases with direct puncture of the common carotid artery, at least in cases where the bifurcation is not located too deep. Yeah, so when it's in a normal area, then you can also do it with direct common carotid artery puncture.
And Rao Vallabhaneni, last comment from you.
Atul, I don't really have a comment, except I'm impressed. I think you had an excellent result. I was worried about it as I started to see, but you had a fantastic result. Apart from congratulating you, I have nothing more to say on that.
Thank you very much. Thank you. So we move over to the next presentation by Dr. Gary Rubin, who's been my mentor and when I went for my fellowship training in the United States. And that is the time when he was in University of Alabama at Birmingham. And the life has taken a full cycle. He went to New York and then he's back to working in Alabama, University of Alabama. He's very fond of horses. I still remember he still holds a good ranch with his choicest of the horses, which he continues to take care of. And Gary is, of course, known for so many things. He's the man who used the first human carotid stent. He's designed the first human coronary stent. And he was also the first person to first describe the series of carotid stenting in human beings. And of course, the GR1 and the GR2 stents are part of history. So over to you, Gary, to discuss about carotid stenting in bilateral disease. There to you.
Thanks, Atul. And it's getting late in Delhi. I'm going to be brief with this presentation. I just want to give a shout out to my dear friend and colleague for decades, Shriyam Iyer, because Shri, I missed you. I didn't see your handsome face when I originally started this program. So Atul asked me to talk about doing carotid stenting in bilateral disease, and just a few observations I'll move through fairly quickly. I would begin by saying that that we have now level 1 scientific evidence that, and I would emphasize, in selected patients, stenting is as safe as endarterectomy, probably safer because of MI and lack of cranial nerve injury. And I believe that we're on a threshold now with our covered stents and really enhanced understanding of patient selection and technique to really take this even further. And we've also shown that our work is really effective in preventing stroke, which is why we're doing this in the first place. And just thinking about all of the enthusiasm for TCAR at the present time, TCAR has not been subjected yet to any level 1 scientific rigorous evaluation. We need to keep that in mind. So that's very important. I just want to emphasize, before we get to bilateral stenosis, that outcomes with carotid stenting are really, I believe, superior to endarterectomy and other techniques. But only if we understand there are definitive contraindications to transfemoral stenting, even listening today to radial stenting. And I think we have to always consider the patient first. Think about the arch, the great vessels, tortuosity and calcification, as Klaus has already mentioned. And we must remember that medical therapy has improved, even for symptomatic patients. Endarterectomy is still a great option. And for patients with bad arches, we still have TCAR. And that we must perform the procedure with care and precision. I want to emphasize the importance of minimizing contrast runs, manipulation, and limiting balloon dilatation, which we've found is very important. Let me move on to bilateral stenosis. Let's think about the risks versus the benefits. And I'm going to say that, and I looked up some recent, very small series on this. And any series of carotid stenting with less than 100 patients is virtually worthless in us understanding what the real difference is. But I can share with you now 30 years of carotid stenting and more than 3,000 cases. And this is my view of what we should be doing when we have severe bilateral disease. It's the symptomatic side first, and then wait 30 days before we do the second side. For the asymptomatic patients, we treat the most threatening lesion first. That's the one most severe with ulceration. We're all experts at looking at these lesions. We know which is the most threatening, and then we should wait 30 days. Now, why? Why stage the procedure? And it's all about what's best for the patient. We have in our hands a very minimally invasive way to prevent stroke in these patients. So we have to really focus on the procedural risk. If we do, and I've done this, if we do both lesions in the same setting, we are essentially doubling the risk of a neurological event for that procedure. And that will count against us. And it counts most importantly against the patient. There's no question that the risk of severe hypotension is dramatically reduced if you just do one side. If you put the stent in both sides, you're fighting hypotension more commonly in these procedures. And then thirdly, there's the risk of hyperperfusion syndrome, and there have been some small series that have documented the increased risk of hyperperfusion syndrome for our patients if we do 2 high-grade lesions in the same setting. So this is brief, but I think it's really to the point. Unless there are really compelling reasons that we should treat 1 lesion at a time, one side, and we should wait and then do the second side. And let's remember that transfemoral carotid stenting for decades has been an outpatient procedure with closure devices, and in my hands, use of bivalve route, and I can ambulate the patients very quickly and send them home, but not if the patient is vomiting or hypotensive or having hyperperfusion type symptoms or has had a neurological event. So let's keep the patient foremost in our minds, what's best for the patient, and let's capitalize on the wonderful element of transfemoral or transradial carotid stenting and being this quick, minimally invasive and very effective way of preventing stroke. Thank you very much. I appreciate being a part of this symposium.
That's been an excellent overview, Gary, for bilateral carotid stenosis. And we are going to invite some comments. Professor Sanjay Tyagi, who's head of GV Pant Hospital and a very avid interventionist on the endovascular field. Would you like to make a comment, Dr. Tyagi? Are you there to unmute yourself?
See, Gary Rubin has been the father of carotid artery stenting, and once he presents, there is no other comment required to be made. So thank you for showing this wonderful and teaching all of us. I visited your Alabama when Dr. Atul Mathur was there and learned carotid stenting from that. So I treat you as a father of carotid artery stenting in the world. Thank you, Gary, for teaching us till the date.
Thank you for those kind words.
Thank you, Sanjay. Thank you. So nice of you. Dr. Girish Varwadekar, our star interventionist, endovascular interventionist in Mumbai. Your comments on bilateral carotid stenting, would you take them on the same sitting or staged?
No, I would not. I would not. I mean, yes, there are newer technologies coming. There have been a group in Germany who's doing total occlusions of the carotid. I would still be a little apprehensive of it. But yes, I would, if you're talking about bilateral carotid stenting, I would not do it, because even when we are doing unilateral, we have seen hyperperfusion injuries, and that's what really worries us.
Dr. Ajay Kaul is a very eminent cardiac surgeon in the city of New Delhi. And a number of times you are faced with bilateral carotid stenosis along with patients who are going for CABG. So what's your approach, Dr. Kaul, on those? You got to unmute yourself. We are not able to hear you, sir.
Yeah, thanks, Atul. See, I would like to mention one thing, that I will talk only about the surgical aspect of it. And I'm sorry, there is something in the room.
Yeah, you want to unmute? Sorry. You are muted, Dr. Ajay.
Oh, yeah. See, I would talk only about the surgical aspect of it. And if there is a bilateral lesion, as usual, we always see which is the significant lesion, and treat it along with the coronary bypass surgery at the same time. Bilateral lesions, very dangerous to treat. We usually avoid treating these lesions. I would say one thing, if there is a minimal stenosis on either sides and the patient is totally asymptomatic, usually we leave these lesions alone and follow them up for a period of time. So bilateral lesion, the symptomatic lesion, to be treated first along with coronary bypass surgery. Here I would mention one thing. There is a patient which has been treated recently with a bilateral lesion and a coronary artery disease that was not very significant. So what I did was, under local anesthesia, we managed the severe form of ulcerated lesion of the coronary artery, of the carotid artery first. And I think after around 15-20 days, we'll take him for coronary bypass surgery. This is the approach that I would follow.
Anil Dhal, he's also one of our stars in Delhi, NCR. Would you like to make a comment on how do you plan out your bilateral carotid cases? And you do a lot of these cases.
So I think Gary's already done the needful, and we really, there's nothing much to add. I think just use good common sense.
That's very sharp and crisp. Shriram Iyer has been a partner with Gary through most of the initial and the further journey of carotid stenting in the US. And Shri, how did you look at, you had looked at a lot of data also on bilateral carotid stenosis, stenting, simultaneous and staged. So what is your experience from the UAB data and the New York data? Would you like to unmute yourself? Shri?
Sorry. So the message was so clearly articulated by Gary that the two main issues, three main issues. Number one, there is rarely, if ever, an indication to treat both carotids at the same time clinically. Number two, and if you do go in that direction, the effects of postural hypotension as well as hyperperfusion are compounded. So I would say that, whether it is stenting, or just like you wouldn't do an endarterectomy bilaterally at the same session, I would hope, there is really no place for treating both sides simultaneously. Just one additional comment. I think over the years, Dr. Rubin and I, we've looked at hundreds of these images and studies which come to us for intervention. At the end of every review, we look at each other and ask ourselves, we used to ask the question, will it fit the 3% rule? And that was very simply, can you deliver the procedure for an asymptomatic patient with a less than 3% complication? And over the years, we kind of, improved upon it to the point where we then modified the question and said, can you deliver the result in an asymptomatic patient with a 0% major stroke? And if anything in your review, whether it's the angiogram, whether it's the patient profile, the lesion is calcified, the arch is type 3, 4, whatever it is, makes you exceed this limit, that's the contraindication for carotid stenting.
Dr. Klaus Matthias, so there is a question from the audience. If you have bilateral TIAs happening and significant carotid stenosis, so how does it change your decision making?
That is a rarity, so that you encounter second carotid artery stenosis, one symptomatic, one asymptomatic. That's not so rare, but that both sides are symptomatic, yes, that is, yes, I would see after imaging of the brain, how does it look like? Imaging of the brain when it's a TIA, it's better with MRI than with CT, because then you can see where you have the spots, the signal intense spots due to, yes, the cytotoxic edema. And then I would make the choice, yes, which side is more affected and is more in danger. It is very rare that I treat in one session both sides. Yes, so that was already pointed out by Gary Rubin, and I'm yes, of the same opinion, and I would proceed in the same manner. Yes, normally you treat one side. When you have TIAs on both sides, yes, also medication might be important. So when you have to know, is the patient already taking something? If not, has he effective yes, aggregation medication, yes, because then normally TIAs will stop. And therefore, to make it short, brain imaging, make a decision, it's really necessary to do both sides. I would prefer one side and would treat the patient with medication, and then in the second session do the other side.
We'll take one, yes.
Can I ask one question?
Yeah, please, Girish.
I would like.
Can I request Dr. Nishit Chandra to start sharing his presentation in the meantime? Yeah, Girish, go ahead.
I'd like to know from Dr. Matthias as well as Dr. Rubin, there have been studies where they've said that they can do chronic occlusions of the carotid. What is their opinion on that?
The question is, that can be done, yes, but the question is it necessary to do it? Because when the patient has no stroke and has one artery occluded, we all know patients who have one of these arteries occluded without any symptoms. Then the collateral flow is sufficient, and then I would do nothing.
Dr. Rubin?
I think Girish.
Yeah.
Gary Rubin. Yeah. And after that, we'll come to you, Vimal. Gary? You want to unmute yourself? Your take on chronic occlusions of the internal carotid artery.
So that are rare cases where you have to do that.
Right.
But I think there is a group in Germany which has been doing it, right?
Yes, we tried that too, but I'm not convinced that it really is necessary. We have other problems.
I agree with you 100%.
Not the chronic occlusion, yes. It was first done by colleagues in Taiwan, yes?
Yeah.
Yes.
Taiwan, Korea.
Dr. Kao in Taiwan was the first to recanalize an occluded carotid artery. But also that didn't convince me. So I would say only when they are symptomatic and there are other vessels also in a very poor condition, so you have an underperfused brain, then it might make sense to attempt it. But otherwise, I would stay away from it.
Vimal Someshwar, yeah, your comment. Unmute
Exactly.
yourself, please. Yeah.
Yeah, it is exactly the same thing. If it is a hypoperfusion with multiple vessels involved, no collateral to that particular segment, then probably opening up a occluded artery would be worth it. But otherwise, I think there's no role.
So, any role for a stress test of the brain? Yeah, you know,
I think there are perfusion tests which are being done.
There's a stress test for the brain.
Anil, there are certain perfusion tests which are being done for the brain also.
Yeah.
We don't do it, but
so we used
excellent.
to.
Shriram, your last comment from Shriram, and then we'll move to the next presentation.
In terms of perfusions, the stress test for the brain, it's a diamox SPECT scan.
شوف يا أمي خرجت كل هذا لما تجلس هنا.
And I would say to Vimal's comment that even if there is indication that the ipsilateral hemisphere is underperfused because of the chronic occlusion and it's symptomatic, doing the carotid occlusion recanalization is so fraught with problems of distal embolization that you cannot control, that you may want to talk to your surgeons for invoking a rare operation that is not very often done. The surgeons can weigh in, and that is the extracranial intracranial bypass. That is one of the few areas where it's not done because of its poor durability, but that's one area where you may want to think about it, rather than exposing the patient to distal embolization and parenchymal damage and neuronal damage from which there is no recovery. Thank you.
Excellent. So let's move forward after this very interesting discussion and to the next presentation. Dr. Nishit Chandra, who's a colleague of mine at Fortis Escorts Heart Institute, Director in Cardiology, is going to show another interesting case to us.
So thank you, Dr. Mathur, for giving me this opportunity. And I shall be discussing a case which is in fact done by Dr. Mathur, and I'll be presenting this very interesting case that I'm sure will generate a lot of discussion. So let's come straight to the case. It's a gentleman who's come from Dhaka, he's a 71 years old male, and he has been a diabetic hypertensive, and he's been a frequent flyer for the cath lab interventions, PCIs to various vessels in 2009, 10, and 12, and finally had a left internal carotid stenting in Dhaka in 2013. And then he presented in November 2019 with only symptoms of a gradually enlarging pulsatile mass on the left side of the neck. That was his only presentation, no TIA, no stroke. And with this presentation, he contacted Dr. Mathur in India. And when he came to us, we subjected him for a CT angio, and we found a large aneurysm, which is just beyond the distal edge of the previous stent in the left internal carotid artery. If we see the images clearly, you can see this large saccular aneurysm just at the distal edge of the stent. So this is about 4 by 4 centimeters large pseudoaneurysm. You can see that precisely that this was the previous stent, and at the distal edge of the stent, you can see this aneurysm hanging, and the size was about 4 by 4 centimeters. And so we took him to the cath lab, and the left internal carotid artery shot confirmed this, and this is a large saccular aneurysm popping out of the internal carotid artery. So you can see the previous stent clearly. And a large saccular bulge. So when should we say aneurysm? When it is more than 50% of the diameter compared to the healthy carotid artery. So this is definitely a very large aneurysm. And usually they present as a pulsatile mass or cranial nerve dysfunction because of the pressure, or TIA and minor stroke. And the incidence is, it's a very, very rare, 1% of the peripheral aneurysms, and majority are pseudoaneurysms. 90% are pseudoaneurysm, only 10% are true aneurysms. The etiology could be atherosclerosis, infection, FMD, trauma, or spontaneous dissection, or even connective tissue diseases. So there was a classification by Attiga, which classified these aneurysms on the basis of their location. Type 1 is in the internal carotid artery, distal to the bifurcation. Type 2 is in the internal carotid artery close to the bifurcation. Type 3 is when it's involving the bifurcation. Type 4 when there is a both in internal as well as the bifurcation and the common carotid. And type 5 is only in the common carotid. So why this classification? Because it has implication on the treatment. And the commonest type, as you are seeing, 65% of them is cornered by type 1 and type 2. And our case also falls into this category. It is a type 1 involving only the left internal carotid artery. So what could be the treatment options? Conservative management, but it is fraught with a lot of morbidity and mortality. Surgical resection, this has been the gold standard. So we discussed with our heart team and the preference of the patient. The preference of the patient was for endovascular intervention. That's why he contacted us. The surgeons were also concerned about the presence of a previous stent, which could cause difficulty in dissection of the carotid, and as well as TIA or a stroke because of the embolism. So ultimately we decided upon the endovascular intervention, and the approach was simple. We took 8 French Cook's sheath and a Roadrunner wire 018, because for a covered stent we need a support. 014 coronary wire would not give proper support for that, and we pre-dilated the lesion with a balloon, and we pre-dilated with about 4 by 20 balloon. And then we put a fluency plus vascular stent graft 6 by 40 covering the mouth of the aneurysm. And we deployed this. And this was the final result. You can see there's the aneurysm is very easily excluded from the circulation. And it was post-dilated with a smaller balloon this time, and this was the final result. So the take-home message is that the endovascular treatment of carotid pseudoaneurysm is feasible and is also a safe alternative than carotid endothelium or than the surgical exclusion. Thank you very much.
Thank you very much, Dr. Nishit. Very well presented. You have made some very nice slides. We'll take comments now, maybe from vascular surgeon friends. Amrish Satvik, Amrish, your opinion. All these things can be done in different manners. So,
this is many congratulations, an excellent result. Just a comment and perhaps a question. The comment would be that, you know, this is clearly a saccular aneurysm or possibly even a pseudoaneurysm, possibly on account of some sort of trauma during dilatation and the first attempt of the stenting. And a surgical approach will be fraught with risk, not because of anything else, but because of trauma to the cranial nerves, because that's exactly the area where the hypoglossal will be stretched very badly and possibly adherent to the saccular aneurysm. So, of course, if it's a very clear-cut saccular aneurysm, one can tackle it surgically, but otherwise a covered stent is a great idea. The question would be, what is your medical management if you've got a covered stent in the ICA post-stenting?
So this patient, we continued with dual antiplatelets for a period of 1 year. Beyond that, we could switch over to, although the patient we did not get back for follow-up, but we could switch over to a single antiplatelet agent. So anticoagulation would not be a plan in our armamentarium.
Right.
I'd like to take opinions on this.
Just another comment, Dr. Mathur.
Yeah.
Let's say if one were to avoid a covered stent, would you consider a stent-assisted coiling of the saccular aneurysm?
Well, that is a good choice. You know, that could be attempted, and that's the second option. Yeah. Klaus, what would you prefer to do in this
coiling
case?
would be much more time requiring, and you would spend quite a lot of money because you need several coils to fill these aneurysms. Therefore, I would have preferred a covered stent.
And only if you're sure it's a true aneurysm and not a pseudo.
Yeah, it looks more like a pseudoaneurysm. Yeah, because it's at the edge of a previous stent. So Amrish is absolutely right. That is the most likely etiology.
The question is, why did the patient develop this aneurysm? Is that due to head movements and interference with the stent there? So does the stenting play a role or not? I know Fates aneurysms close to the skull base, which are, yes, after a car accident where you have a whiplash trauma of the head, and then some of these patients develop Fates aneurysms close to the skull base. Yeah? But here's the question, why has the patient an aneurysm at the end of the stent?
So most likely it is due to trauma of a post-balloon dilatation during the initial stenting procedure. So they may have injured the distal edge and ultimately which may have evolved. This is just a theory. We don't know because he was not being followed up for 5-6 years in between. But that is a possibility.
Dr. Mathur, may I make a comment?
Yes, please. Go ahead.
Good evening. Excellent presentation.
Yes,
just wanted to ask, in light of this, would you consider a tapering stent as being a more standard approach for carotid stenting rather than a fixed diameter stent in light of in this case where there was some injury distally?
Yeah, so injury is not due to the stent being not tapered, but probably due to over-aggressive balloon dilatation, which was beyond the stent. But tapered stents are definitely have their own advantages, and which are now most of the companies are providing with these tapered stents. So that's a very good point. And maybe we'll take an opinion from Max Emmer on carotid aneurysms. Max, would you shed some light on your view? And then Dr. Virender Bedi is there with us.
We have seen only in our experience small cases of this kind of aneurysm. For me, it's of course, obviously, of course, aneurysm, and for me, it's connected to the first procedure at the edge of a stent, and I think probably there was a dissection and the patient has developed this false aneurysm. So for me, there is no other explanation. Second is that what is the technique to cover, to do that? One is what Bruce has proposed, which is coil embolization. The other that we may consider is glue under occlusion of the internal carotid. And today, the glue bond and other devices that we are using today in false aneurysm at the femoral level works very well in 5 to 10 minutes. So it's something you may consider if you don't want to have so much metal in the carotid artery. Otherwise, I think what you picked was the right technique, which is placing a self-expandable stent in this area, and the result was angiographically excellent. So I think you did well.
Thank you, Max and Dr. Bedi. And in the meantime, can I request Dr. George Joseph to please share his presentation so that we can go next to him.
Just a question regarding the choice of stents. Again, I think good old days, the best stent, and probably a lot of my friends in US as well as in Deutschland will know the Viban stent. That was something I think which was a wonderful stent out here in this kind of a situation. Probably if you have a Viban, that is a much better stent in terms of, you know, the mobility of the stent and all. And we have used it a few years back in a patient with a large giant aneurysm of the carotid. And that seems to work very well. So if any opinion is there about from this, about Klaus, Matthias, or anybody else for that matter. The choice
So just one comment, sir. I had used Viban for aneurysm and the profunda femoris. There was an aneurysm there, large aneurysm post IEBP implantation.
Right.
So it worked fantastically well. I mean, the patient was on follow-up and.
Yeah, because that is one.
Good evening, everyone. Sorry, I'm just
very flexible stent, and even with the neck mobility, it doesn't really, you know, bother you too much.
The limitation. So it's a very easy to use stent. Unfortunately, we don't have it in India now.
Yes, and very easy to deploy. Very easy to deploy, sir. Also,
it's a simple technique, as you call it.
Yeah. Klaus, your comment on Viban? Yeah.
The limitation on Viban is the size of the guiding catheter or the delivery sheath that you need to deliver, because here I don't know, I don't quite recall what it was ultimately, what was the size of the self-expanding stent that you did, because if you are
40.
going, sorry, what is the diameter?
6 by 40.
6 by 40 should be okay.
We were going to stay
Yes,
only
but,
with internal carotid. Yeah.
The introducer are large with the fluency.
Yeah, 6 by 40 should be okay, because larger covered stents in the Viban family require a larger delivery sheath. And I think you had an 8 French shuttle or 8 French guide. And so that could be the limitation, especially if you want to come down into the common.
Yeah, one question to Dr. Max or Dr. Klaus, that in the light of this case with an aneurysm, now post-carotid intervention with a stent in the neck, in the extracranial part, what precautions would you advise to the patient about compression, external compression, the movement of the head, or?
It's normal behavior. So there is nothing special for the patient. That was different when it was already mentioned that Gary Rubin started stenting at that time. That was a balloon expandable stent. Yes, and these stents deformed. I started that in the early 80s with the wall stent that was available in Europe at that time, not in the United States. And that is not, it's fairly stiff when it's deployed, but it has not this disadvantage of deformity developing over time. It keeps its shape. Yes? So that was, I think, an important difference.
I will remind Gary about the first publication which I had made when I was with him on balloon expandable stents, the Palmer stents, which we used to do. The initial 110 cases at the University of Alabama at Birmingham. And we had started seeing a lot of crimped Palmer stents coming to us, which needed treatment again. And this was the publication following which most of the carotid stenting techniques moved to self-expanding stents. So do you remember that, Gary, the paper we published in AJC?
I think that Gary left.
Yeah. So Gary is on mute
just
mode.
To say that Klaus was probably talking about the wall graft, not the wall stent.
No, I was talking on the wall stent because we started stenting in the 80s. So now.
All right. Okay.
Yes.
So that is a bare stent which you're talking about.
Yes.
And that was spare stent, but that was a self-expandable stent, not balloon expandable. So we learned then that compression to the neck, movement of the head, and so on can deform a balloon expandable stent. Therefore, we left that completely. I would use it only very, very high up, close to the skull base, but otherwise not in the neck area.
Any role of mesh covered stent, flow diverter stents in these?
Yes, covered stents, that's a different
flow
thing.
diverters. Yeah.
Yes, yeah. There are different types. I would, in the neck area, here use some which is flexible enough, yes. When it's higher up or close to the aortic arch, it can be also a stiffer version. So that depends on what you have available also in your lab.
I would comment. There is two risks with the stent. The first risk is migration. Over more than several thousand cases, we had only one migration of a carotid wall stent that really uncovered the lesion. It exists, but probably it was our fault. The stent was not well applied. The post-dilatation was not excellent. But it may also be an explanation in the case you have shown, which is an uncovering of a lesion, a small migration of the stent that is uncovering the dissection that was not completely covered and explaining the false aneurysm. The second complication of the carotid stent is the compression. We were among the people that started with a balloon expandable stent because it was the only stent that we had. So we placed several hundred balloon expandable stents. And we observed, and probably it was the work of Jerry Doros and others, compression of the stent. Because of that, everyone moved to self-expandable stent, promoted by Klaus and Gary, and we were satisfied because we didn't observe any compression. The luckiness, I would say, is that the old patients are not playing basketball, they are not playing football, they are not doing a lot of gym, so really they are not moving so much their neck. On the other side, a patient that is young, probably could be very more active, and this is why I said in the beginning, we are not in favor of placing a stent in a young patient. Because whatever you say, he is not careful enough, and in my opinion, a stent is not the natural treatment of a lesion here in the neck, because you have to remember that it's the more mobile articulation of the body. You move the head in all directions, and because of that, really, the stent has to be very stable. So this is why I think we have always to take consideration of what stent we are going to place, how the patient is active, what does he do, what does he play. And I don't want to say, but we had strange complications in some cases. I don't want to tell them today, but really, I think you have to consider that. What are the activity of the patient? What he's doing? What he's going to do after the procedure? It's something I think it's extremely important. Thank you.
Thank you very much. This has been an excellent discussion on this case, and more could go on. We can continue to use the chat box. We'll move to the next presentation. And this is George Joseph is one of our stars, professor of cardiology at CMC Vellore. He is renowned in this country for all kinds of exotic endovascular procedures. He has a large experience of treating Takayasu's arthritis patients also, which is a disease not commonly seen in other parts of the world. So George is going to show us a case of Takayasu's arthritis and discuss his tips and tricks on that. Over to you, George.
Thank you, Atul, for this opportunity to present our work. I will talk about Takayasu arthritis, which is quite different from what we've been talking so far. And the main issues in dealing with carotid interventions in Takayasu arthritis is these three. One is we deal with a lot of occlusions of the common carotid artery, so we need to cross them. Second is a problem of cerebral hyperperfusion, which is probably worse in this disease. And the third is the problem of restenosis. So I will present a case which highlights all these three problems. So this is a 31-year-old lady who came to us with right-sided weakness and aphasia, which she had developed in February of 2015. And that's the imaging showing a large left middle cerebral artery territory infarction. And on the right is the angiogram that we did, and she had occluded innominate and left common carotid arteries, and she essentially had only one supply to the brain, the left vertebral artery, and a patent left subclavian artery. So we opened up her innominate and right common carotid artery. We crossed this long lesion with an Astato wire, which is a wire from Asahi. And then we dilated the lesion with a 5 millimeter balloon and deployed this long stent covering the entire lesion and probably ending in the internal carotid artery. The external was not recanalized. And we accepted this 47% residual stenosis at the point where the red arrow is. Over the next 2 days, she developed vomiting and headache, and imaging showed some mild cerebral edema, which fortunately settled down. But the image on the right shows that this one artery was able to perfuse quite a lot of the anterior circulation on both sides. She came back to us the next later, I think this was 10 months later, and you can see that the stent has diffuse in-stent restenosis, and we are almost back to where we started. So we wired this long stent and did a balloon dilatation, and then followed that up with a drug-coated balloon, the Impact Admiral, 6 millimeters in diameter and 12 centimeters in length. And immediately got a very nice result. And then we went to work on another couple of lesions. And when we came back an hour and a half later, we found that there was significant recoil of the intima, although the flow was very good. We had managed to open out the right subclavian artery. The blue arrow shows the right subclavian where it was occluded. And we also opened the left common carotid artery. And because of the previous experience of headache and vomiting, this time we did not stent this artery. We just balloon dilated it with a 3.5 millimeter long balloon. And this is what we achieved on that day. And that was in August of 16. Then she came back in March of 17, and now a lot of changes have taken place. Our original innominate right carotid stent is doing fairly well, but she's now developed a new lesion in the right right subclavian artery. The left carotid artery has become much smaller in diameter, the lumen that is, and there is a new occlusion of the left subclavian artery, which was not there earlier, and which was the only vessel which provided blood flow to the brain earlier through the left vertebral artery. So it's probably fortunate that she now had a patent right common carotid artery. So this time we balloon dilated the right subclavian artery with a 6 millimeter balloon, stented the left common carotid with a long epic stent, 10 centimeters long, and recanalized the left subclavian and put in a epic stent here too. And that was March of 17. Now 7 months later, the two new stents were put in. The left common carotid and the left subclavian have restenosed to the point of occlusion. The right carotid stent is doing well. The right subclavian is fairly okay. So we balloon dilated the left subclavian stent with a 6 millimeter balloon, and also balloon dilated the left common carotid stent. And we were not very happy with the intima, which looked a bit shaggy. So we had to reline it with another stent. And that was October of 17. And then she came back to us. And this time we had restenosis, not so bad, in 3 locations marked by these arrows. And the 2 are in the left common carotid. We treated this with a drug-coated balloon, and also the left subclavian artery with a shorter drug-coated balloon. And yet another follow-up, we found that the left carotid is now doing better, but there is now another restenosis right on top, but everything else seems reasonably okay. So that was treated with a drug-coated balloon for a second time. And then she has done well. 6 months later, she came to us, that is August of 19, And all her pulses are good in both upper limbs, both carotids. We did not do an angiogram at this time. She's asymptomatic. And then throughout this period, from 2015 to 2019, she's been on immunosuppressive therapy with deflazacort and mycophenolate. And you can see the inflammatory markers over the years. We never got it completely to normal. There's always a little above the limit, either the ESR or the CRP or both. So that's a very typical kind of Takayasu case where we have to re-intervene for restenosis. We have the problem of hyperperfusion, and we have this crossing of occlusions as an issue. Very similar case to the one I showed. In this case, again, only the left vertebral is supplying the brain. So we opened the innominate and got a vertebral to flow, and we opened the left common carotid, and we stented it. And you can see that this case, the stent has positively remodeled over a period of 6 months, and it has become bigger in size. And this is follow-up at 3 years and then follow-up at 6 years. So this is a case where there was no restenosis, and the stents have all done very well. Now, this particular case, the right carotid was not recanalized, and we did this ultrasound, and you can see there is fairly thick intima media, and within that there is this black area in which there are some small channels which show some flow, and this intima media was quite thick, 2 millimeters, and the adventitia is also thick. The internal carotid artery was patent. So that is one requirement for these cases, that the internal should be patent. Usually the internal is supplied from collaterals that link onto the external, and the common is occluded, and that's what we recanalize. And when we recanalize and stent the common, this is what the left side looked like. The left carotid was stented, and you can see the stent in the artery on top. And this does not show that intima media differentiation. And this is another thing that we noticed. There are these intravascular channels in these occluded arteries, which if you recanalize, and they all coalesce and become a single large channel. This is the another example I want to show. A lady had come to us with a stenting of the right carotid, innominate done elsewhere. So we stented the left carotid and the left subclavian, opened up the left vertebral, and went on to work on the renals. And when we finished that, she suddenly developed seizures on the table, and she had this huge cerebral bleed, which was ultimately fatal. So I'll just briefly touch on our data. We've been working on Takayasu arthritis for 25 years, 853 patients, 2,200 lesions, and 3,400 procedures on this. And they come from a subset of 1022 patients. So vast majority, 853, had percutaneous interventions, 102 had surgery, and 143 had medical treatment. And if you look at the lesions treated, carotids come fourth. We had 307 carotid lesions that we treated among these 2,200 lesions treated. And if you look at the outcome for the carotids alone, the 300 lesions that were obstructive lesions, leaving out 8 aneurysms, 40% of these were occlusions to start with, and we needed an average of 1.48 interventions per lesion. So we had to re-intervene on quite a few of them. And then we got a follow-up in 70% of these patients, of which 82% was an angiographic follow-up, which was at approximately 4.5 years after the last intervention. And a successful outcome was obtained in 86% of these. So this is not like a primary patency, it's more like a secondary patency. But it is quite heartening in this otherwise quite difficult to treat disease. And we do have complications. We had 5 deaths, and all of these were due to intracranial bleeds. 3 were due to hyperperfusion, and 2 were after lysis for an occluded stent elsewhere. We had 3 embolic strokes, 5 TIAs, 5 stent thrombosis, and 7 cases we failed to cross the lesion. And I talked a little bit about drug-coated balloons. We have some data on these now. If in Takayasu arteritis, in-stent restenosis, most of it is in the subclavian artery, a few carotids and few renals. And if you use them in PI1, that is percutaneous intervention 1, that is like a prophylactic use, they don't seem to do too well. But if you use it at the first restenosis, where you're dealing with a restenosis for the first time, they do very well, and the restenosis rate drops to almost half. And if you use it in restenosis third, fourth, fifth times, these are probably a group that is more prone to restenosis. The outcome is not good. But if you use it a second time, then you get a good outcome comparable to just using it at PI2. So this is preliminary kind of data, but it shows there is some benefit with drug-coated stents. So 3 points I had made earlier, some messages on that. So when you choose a common carotid artery to recanalize, it's good if you can see these intravascular channels through them when you do a selective wedge angiogram. And you should see the internal carotid reforming from collaterals. Then it's a good case to do. But if the internal carotid is occluded, then it's a contraindication to recanalization. And how to avoid or treat cerebral hyperperfusion, we stage the recanalization of multiple occluded arteries, and we avoid opening the carotid arteries in patients who have very high systemic blood pressure, which is not controlled. And we do not dilate an artery in the first round more than 5 millimeters. We prefer not to stent in the first sitting. We avoid dual antiplatelets pre-operatively. We may add it on later if we are sure there is no hyperperfusion. And like the case I showed, the second carotid artery which you may treat should be treated like the first, because the anterior communicating artery may not be well developed, or there may be a distal intracranial stenosis. And so it may behave like the brain may still behave like it's been underperfused when you do the second artery. And as far as restenosis goes, it's very important to control disease activity. Balloon dilatation is a very easy way to deal with restenosis, gives good immediate results. And it's important to use long balloons to prevent melon seeding and intimal embolization, which was one of the embolic strokes that we had. And we found that repeated dilatation yields a good secondary success rate, and drug-coated balloons may be beneficial in treating in-stent restenosis in Takayasu arthritis. Thank you for your attention.
Thank you very much, George. This has been a very exhaustive overview of this disease process, which you see more in this part of the world. And maybe I'll ask Dr. Mirwat Alasmang if we see such cases in Saudi Arabia also. Mirwat, are you there? And can you unmute yourself? So the basic crux of the matter is that keep as many supraaortic vessels running as you can. Do them in a staged manner. Keep an eye on the disease activity, because the recurrence is related entirely to presence of active disease and the immunosuppressive drugs which George has outlined. If there is any comment, we'll take one more comment on this, because we went beyond the time.
Can I just ask one question? Yeah.
Yeah,
for
please.
a long time for osteoarthritis, the standard treatment was just doing POBA, and POBA. And I think George has been a path breaker in that sense, that he's always been very, very clear that he wants to stent all these lesions. So any thoughts, George, why have you deviated from the conventional path?
No, it's not that we stent all our lesions, but we stent the vast majority of our lesions. And we find that stenting gives far better acute results. There is recoil is less, dissection is tacked down. We get a very good flow, and especially in critical vessels like carotids, we would hate to leave a dissection there. Now the problem is restenosis, and we found that restenosis occurs with both balloon dilatation and with stenting with equal rate. There is no, in our experience, it's not like balloon dilated lesions restenose less than stented lesions. But you need to deal with them, and that is what we worked on and found that repeated dilatations solves that problem. And now we tend to use drug-coated balloons for that.
George, did you ever have to use cutting balloons in your carotids?
Yes,
Because a
we
number of
did
them
a
are
lot
very
of
fibrotic lesions, right?
Yes, we in the early 2000s we used a lot of cutting balloons, about 150 lesions, and found that it's of no benefit whatsoever over plain balloon, and it increases the risk of rupture and bleeding and pseudoaneurysm formation. So we've given up on it. We don't find any benefit. Now we have these non-compliant high-pressure balloons, and that does the job for a fibrotic lesion quite well.
Is there a role for drug-eluting stents after the restenosis? Now that we can go up to 5.5 millimeters?
I don't know. I have not had the opportunity to use drug-eluting stents. We have used drug-eluting stents for small vessels like coronary arteries, small renal arteries, and vertebral arteries. And they don't do well. The restenosis rate is around 40%. But in the same situation, bare metal stents has a restenosis rate of about 50%. So it's about 10% better, but both are pretty bad, So we are very reluctant to take on coronaries nowadays because they tend to restenose, and small renals and the vertebral, unless it's just that ostial vertebral lesion, we don't take it on.
Can I request Horst Sivert to share his presentation? In the meantime, we'll take a last comment from Amrish Satvik.
Yeah,
Horst, would you like to share your screen now? Yeah.
Dr. George, excellent presentation as usual. Just a few queries I have. Is there a lower limit of ESR and CRP that you consider as acceptable before taking these patients on for stenting? Secondly, is there an upper limit of the internal carotid that you're not willing to touch? Let's say you want to preserve that for an aorta to carotid bypass. And finally, do you ever consider doing a cerebrovascular reactivity test in patients who've got more than one arch vessel disease to make sure that they will not have hyperperfusion syndrome?
We've not, I'll finish the last one first. We've not done this reactivity test at all. Most of these patients are, in a very bad situation. Most of their arch vessels are blocked and they've stroked and they're extremely dizzy. So we just have to do something, and we cannot say that, okay, your reactivity test is not good and so we can't do it. So it's, we've had to do them. Sorry, I've forgotten your earlier question.
Is there a lower limit of ESR?
Yeah. So ESR and CRP, if you can get them to normal before you intervene, there's nothing better than that. But the practical reality is there are 2 or 3 things. One is, even with the best of medical therapy, many of them do not become inactive. Second is, they may be not compliant with the medicine. So you may wait and they don't become inactive. Third is, they have symptomatic disease which needs urgent treatment. So you cannot wait for the disease to become inactive. So because of all this, roughly half of our patients are not inactive at the time of the first intervention. That's the practical reality. But if you can reach that situation, patient is inactive disease, and then you intervene, that's the best thing. You'll get the best results in that. Active disease worsens restenosis.
Thank you very much, George. And this has been a very enlightening presentation and discussion about Takayasu's arthritis, which is majorly seen in this part of the world.